Psychiatry. It grapples with the most complex territory imaginable, the human mind, and often operates in a realm of, well, profound uncertainty.
Hmm.
It's a field just ripe with debate, which brings us neatly to the source for this deep dive shared by one of you.
Yeah, today we're really immersing ourselves in Jan Pohl's The Politics of Mental Illness, Myth and Power, in the work of Thomas S. Szasz. Came out in Dutch, originally way back in 1984.
Right.
But it offers this really crucial, critical look at psychiatric thinking and practice. And honestly, it still feels remarkably relevant today.
Absolutely. And our listener, they specifically wanted to explore these critical perspectives on psychiatry and really get a handle on the historical currents that sort of shaped them.
And Thomas Szasz is, I mean, he's such a central figure in that critical landscape.
Definitely.
Pohl's work gives us a really insightful analysis of his ideas, but importantly, within that historical context.
So our mission, if you like, for this deep dive is to pull out the core arguments of Szasz, as Pohl's presents them anyway, and then examine the history, the evolution of psychiatric practices that Pohl's describes from his own experience, too.
And figure out why these debates, why they still resonate so much now.
Okay, so where do we start? Let's unpack Szasz's central claims, maybe, according to Pohl's.
Good idea. So probably the most foundational argument from Szasz, as Pohl's lays it out, is this idea of the myth of mental illness.
Right, the big one.
Exactly. Szasz argued that mental illness isn't a disease in the way we think of, say, an infection caused by a germ. It's not biological in that traditional medical sense.
So what is it then, according to him?
He basically posited that it's largely a social construct, a way society labels and maybe even controls behaviors that are seen as undesirable or just different.
That must have been a pretty radical idea back then.
Oh, absolutely. And this perspective, it directly feeds into his really strong stance against coercion in psychiatry. That's sort of his second major point.
You mean things like involuntary commitment?
Exactly. He fundamentally opposed involuntary commitment and treatment. He saw it as a massive violation of individual liberty, of autonomy.
So for Szasz, freedom trumped health, in a way.
Pretty much. He argued that even if someone's choices seem harmful to themselves, the freedom to make those choices should, in most situations, outweigh someone else stepping in, whether it's the state or doctors, imposing help.
Okay. And how did he see the role of psychiatry in society then? Did that tie in?
Oh, definitely. This links right into his view of psychiatry's social function. Szasz believed it often acted as a tool of social control.
Social control. How so?
Pohl's highlight Szasz's idea of psychiatrists being like social tranquilizers, reinforcing the dominant societal norms and kind of marginalizing people who deviate too much.
So a function beyond just treating an individual's illness, more about keeping society running smoothly, maybe.
That's the implication, yeah. It suggests psychiatry might be serving the status quo just as much as, or maybe even more than, helping people in distress. A really powerful critique.
Wow. Okay. And Pohl's also mentions Szasz's focus on responsibility.
Yes, Szasz was big on this. He argued that adults should generally be held responsible for their actions.
And labeling it mental illness gets in the way of that.
That was his fear, that attributing behavior solely to mental illness could become a way to dodge dealing with difficult social or ethical problems, avoiding the harder questions about behavior in society.
Makes sense.
And Pohl's also notes his broader skepticism. He was wary of what he called the medical scientific ideology.
What did he mean by that?
Basically, the tendency to frame very fundamental human experiences like suffering, happiness, meaning primarily through this lens of illness and health. Szasz worried that doing that obscures the personal, the social, the existential dimensions.
Right, reducing everything to a medical problem.
Kind of, yeah. So a really challenging set of ideas questioning the very bedrock of psychiatric thought and practice at the time.
Okay, so to really get why these ideas emerged and had such an impact, Pohl's gives us his own perspective, his own experiences inside psychiatric institutions in the Netherlands. This is where it gets quite vivid, doesn't it?
It really does. Pohl's talks about these three experiences that basically shaped his whole understanding. His earliest ones, this is before 1963, paint a picture of very paternalistic institutions.
Paternalistic meaning?
Meaning the doctors and staff made decisions for the patients, assuming they knew best. Involuntary commitment was standard. Coercive stuff like electroconvulsive therapy, ECT.
Yeah.
Often done without anesthesia back then. And the focus was very much on biological or somatic treatments.
And Poles mentions some surprising reasons for people being committed back then,
He
too.
does. He talks about people being locked up for things like repeated bicycle theft or minor fraud, things we'd probably see handled by the courts now, not a psychiatric hospital.
Hmm.
He even mentions a professor from Amsterdam who'd bring patients in for observation, and they could end up staying for ages with very little actual therapy happening.
Yeah.
And some really questionable discussions around consent, especially regarding sexual offenses.
Right. So his next experience as a resident.
Yeah, that was between 1963 and 1968. That gives us more of a day-to-day view. He describes these admission wards where all sorts of patients were mixed together.
And patient rights.
Minimal, extremely limited. ECT, still often without clear consent, was common. And people could be kept involuntarily long-term, based on just these really brief monthly notes in their files.
Sounds almost like an administrative process rather than focused care.
It has that feel, doesn't it?
Mm.
Poles also mentions there wasn't much talking therapy, medications. The early antipsychotics like chlorpromazine, antidepressants like imipramine were very common.
And work therapy, I think you mentioned that.
Yeah, things like assembling clothespins, really basic tasks. And interestingly, he notes that deinstitutionalization, moving people out of large hospitals, which was starting in the U.S., didn't really catch on there as quickly.
Why not?
Because for many long-term patients, the institution was their home. They didn't really have anywhere else to go or want to go.
Huh. Okay, and the third experience at the university clinic.
Right, in Groningen. That marked a real shift. He saw growing skepticism about purely physical treatments, like insulin coma therapy.
Which sounds terrifying.
It does. Psychoactive drugs became the main tool, but there was also this growing emphasis on psychotherapy, especially psychoanalysis.
Some more talking.
More talking, yeah. And other therapies started coming into client-centered approaches, behavior therapy, though maybe with a bit of resistance at first.
And this is the period when anti-psychiatry starts to emerge more strongly.
Exactly. Figures like Irving Goffman, famous for his work on asylums as total institutions, R.D. Laing, who explored the subjective experience of psychosis, David Cooper, a very radical critic. They were becoming really influential.
But Poles makes a distinction with Szasz, right? He doesn't lump him in completely with them.
That's a crucial point Poles makes. He calls Szasz a critical psychiatrist, someone critiquing from within the field, using its own language to some extent, whereas figures like Laing and Cooper were seen as more radically outside, part of the anti-psychiatry movement proper.
And he mentions a Dutch equivalent to anti-psychiatry.
Yeah, Jan Verdrein. Poles sees him as maybe the key Dutch anti-psychiatrist figure.
Okay, so Poles then shifts focus a bit, looking at the U.S. context through another book.
Right. He draws on Nina Ridnor's history of the mental health movement in the U.S., and he points out something interesting. Its early focus, back around 1909, wasn't always purely on patient well-being.
What was it focused on then?
Often broader societal concerns, like screening immigrants for mental fitness. That was a big thing early on.
And the medicalization of behavior.
Yeah, Poles highlights the rise of the child guidance movement and this trend of framing a social behavior as a medical issue. He mentions Karl Menninger, who argued that criminals were actually psychiatric patients needing treatment, not punishment.
A view Szasz would strongly disagree with later, I imagine.
Absolutely.
Right.
Sharply. Another factor Poles mentions is World War II.
How did that play a role?
The huge number of men rejected for military service for psychiatric reasons. It suddenly made mental health a much bigger public issue. People started talking about it more.
Ah, okay.
And around the same time, you have the World Health Organization, the WHO, broadening the definition of health. Not just absence of disease, but complete physical, mental, and social well-being.
Which vastly expands the territory of mental health, doesn't it?
Hugely. And the mental health movement in the U.S. started pushing harder for government involvement funding care, setting up laws around involuntary commitment.
Which leads us to what Poles calls a turning point year.
Yes, 1961. Really pivotal. You had a cluster of incredibly influential critical books all published that year.
We mentioned Szasz's myth of mental illness. What else?
Goffman's Asylums, Laing's Self and Others, and also Michel Foucault's Madness and Civilization, or Folie et Déraison.
Wow, all in one year.
Right. Poles sees this as kicking off a period of major upheaval in psychiatry. Lots of confusion, new and often conflicting treatments popping up, social clashes.
And deinstitutionalization really taking off then with all its problems.
Exactly, the complex, often messy consequences of that. And Poles even hints that this questioning might have, paradoxically, paved the way for a later return to more biological approaches.
Fascinating. It really paints this picture of a field in turmoil grappling with its own identity. So given all that history, how does Poles actually evaluate Saz's contribution? Does he agree with him?
Well, he definitely acknowledges Zaz's huge impact. Forcing psychiatry to really re-examine itself was crucial. But Poles is also critical of Zaz's style of argument.
Oh, so.
He finds it often more accusatory, more based on moral judgment than on, let's say, balanced, rigorous reasoning. And a key disagreement is over that definition of illness. Poles doesn't buy Saz's strictly biomedical view.
What does Poles propose instead?
He argues for a more integrated biopsychosocial model, one that takes psychological and social factors seriously alongside the biological ones, not just body's machine.
And this connects to that idea of territory you mentioned, how the medical profession claims ownership.
Exactly. Poles really digs into how professions, especially medicine and psychiatry, define what counts as a disease they get to treat. It's about power, essentially.
He gives examples, right?
Yeah, he quotes Kendall saying psychiatrists understand schizophrenia best, implying it's their domain.
Yeah.
And Wolfer's saying hyperventilation isn't a real disease, so it doesn't belong to physicians.
So defining illness is also about defining professional boundaries.
Precisely. Poles uses this to push back against the idea that disease concepts and professional power are separate things. They're deeply intertwined.
And Poles also noticed a shift in what patients wanted.
Yeah, he observed this growing dissatisfaction. People seemed less happy with just a purely scientific doctor, someone technically brilliant but maybe lacking warmth. They wanted a more humane doctor.
Suggesting the purely biomedical model might miss something important for the patient.
That's the idea. It might not meet deeper needs for empathy, understanding, just human connection.
Poles also tackles the tricky issue of informed consent, doesn't he? Especially with certain therapies.
Right. He raises questions about therapies that might rely on paradox, or even, arguably, a kind of deception. If full transparency might make the therapy less effective, what does informed consent really mean then?
Big ethical questions there.
Huge. And interestingly, Poles is also somewhat critical of all the increasing rules and regulations in psychiatry.
That seems counterintuitive. Aren't regulations meant to protect patients?
That's the intention, of course. But Poles suggests that things like multidisciplinary teams, review committees, constant oversight, even the influence of insurance companies in the state, while aiming for safety and quality, might actually create more bureaucracy and, paradoxically, make patients feel more powerless, further removed from the actual decision-making about their care.
An interesting perspective. Then Poles talks about these fundamental quandaries in psychiatry. What are they?
He identifies two main ones. First, just how wide should psychiatry cast its net? What actually falls under its domain? Is it just severe psychosis, or does it include anxiety, life problems, unhappiness? Where's the boundary?
Okay, the scope question and the second.
The second is about its social function, which we touched on with Zaz. Is psychiatry primarily about treatment and helping people feel better? Or does it also inevitably serve a role in social control, managing difficult behavior, maintaining order?
And Poles thinks these aren't fully resolved.
He argues these fundamental ambiguities, these unresolved tensions, are at the heart of many ongoing challenges and debates within the field.
Makes sense. And what about rationality? That comes up too, right, in relation to psychiatric disorders?
Yes. Poles engages with arguments, particularly from Moore, about irrationality being a key feature of mental illness.
Does Poles agree?
He acknowledges irrationality can be present, sure, but he pushes back against seeing it as the whole story. He stresses the need to understand the motives behind seemingly irrational behavior and the social and cultural context.
Meaning?
Well, he points out that many beliefs people hold strongly religious, political, could look irrational from a purely logical, detached viewpoint. Does that make them symptoms of illness?
Good point.
He cautions against too easily equating irrationality with being somehow less human or automatically requiring intervention. Context matters.
Okay, so moving into Chapter 7 of Poles' book, the focus really narrows onto coercion, which we know was central for Saz.
Absolutely central. Saz's opposition was principled, almost absolute. Liberty and autonomy above all else. Poles uses that as a starting point to examine the legal side of things.
Like how the law views psychiatric disorders in relation to free will and responsibility.
Exactly. And how that connection, or perceived connection, justifies legal interventions like involuntary commitment.
Poles makes a comparison here between physical medicine and psychiatry regarding coercion, doesn't he?
Yes, and it's quite stark. He points out that in general medicine, Forcing treatment or isolation like quarantine is usually reserved for highly infectious diseases that pose a widespread public health emergency.
Like a pandemic situation.
Right. Whereas in psychiatry, the justification for overriding someone's autonomy can be based on perceived risk of harm just to themselves or maybe to one or two other people. The threshold seems different.
Interesting comparison. Does polls provide data on how common involuntary commitment is?
He does. He looks at statistics from the Netherlands, the US, England, and Wales, showing historical trends and how the legal frameworks differ.
And the reason for commitment has changed over time.
That's a key point. The legal basis has generally shifted away from that older paternalistic idea of acting in the person's best interests towards the criterion of dangerousness, being a danger to oneself or others. That's become the more common legal standard.
But predicting dangerousness is notoriously difficult, isn't it?
Extremely difficult. Polls brings in research, like Dijkstra's work on suicide, suggesting the link between having a specific psychiatric diagnosis and actually being dangerous isn't always as clear-cut as the legal process might assume.
Right.
He also talks about this category of virtually voluntary or non-opposing patients, people who aren't formally committed but might feel pressured or lack real alternatives, raising questions about how truly voluntary their admission is.
And what about mistakes? Does polls address the possibility of wrongful commitment?
He acknowledges that clear-cut documented cases of completely unjustified commitment seem rare, but he absolutely points out the potential for errors in judgment, for prejudice to play a role, or even, though hopefully very rarely, for malicious intent.
A crucial issue he raises is the lack of feedback, right?
Yes, this is critical. There's often no systematic mechanism to track whether an involuntary commitment actually helped, whether it was truly necessary in hindsight, whether the prediction of danger was accurate.
So it's hard to learn or improve the system.
Exactly. Without that feedback loop, it's difficult to know if these profound interventions are justified or effective long-term. Polls really highlights the deep ethical bind here, the choice between intervening against someone's will versus potentially leaving them to face severe difficulties or even harm alone.
So where does Polls himself land on involuntary commitment ultimately? Does he agree with Szasz that it should just end?
In principle, yes. His conclusion actually aligns pretty closely with Szasz's. He thinks involuntary commitment should be abolished.
But there's always a but.
But he's also a pragmatist. He recognizes the huge practical challenges that would create. What are the alternatives? How do you support people in extreme crisis without resorting to coercion? He stresses the absolute need for effective, well-funded alternatives if abolition were ever to happen.
Right. Okay, so that brings us towards the end, to the epilogue, where Polls looks at developments after his book first came out. What did he see changing?
He observed a definite shift. The influence of critical psychiatry and anti-psychiatry seemed to be waning
Replaced by?
by a much stronger focus on empirical research, on data, a more scientific orientation, you could say.
And the DSM plays a big role here, the Diagnostic and Statistical Manual.
A huge role. Bowles discusses how the DSM system, with its focus on classifying based on observable symptoms, really took hold.
Did he see that as positive or negative?
Mixed, I'd say. He notes its shift away from a purely biomedical model towards something more biopsychosocial, at least in theory, and its role in stimulating research and creating a common language was important. But he also flags its limitations, particularly how it's often used in legal settings to determine responsibility or need for commitment, even though it wasn't really designed for that and might not be suitable.
And this ties into a broader trend he calls the neo-positivistic turn, evidence-based medicine, EBM.
Yes. The rise of EBM, with its strict hierarchy of evidence valuing randomized controlled trials above almost everything else, really impacted psychiatry too.
Creating a tension.
Definitely.
Yeah.
Polls point to this tension between being sort of biomedical in principle, following the EBM model, but needing to be biopsychosocial in practice to actually help patients effectively. He keeps stressing that things like rationality and the quality of the therapeutic relationship remain absolutely vital in psychiatry.
Does he worry about downsides to this very scientific, evidence-based focus?
He does raise concerns, like the risk of doctors becoming seen just as technical experts applying protocols rather than healers engaging with the whole person. This could lead, he suggests, to more patient dissatisfaction, more complaints.
And he saw the state getting more involved too, in the Netherlands at least.
Yes, increasing government intervention and funding, setting fees, managing hospital budgets. He worried about the potential impact on the confidentiality of the doctor-patient relationship and just shifting the power dynamics further away from the individual patient and doctor.
And there was a specific Dutch law change that had unexpected results.
Right, a new law on special admissions to psychiatric hospitals. The hope was it might reduce coercion, but apparently it led to an unexpected tripling of involuntary commitments.
Wow, why?
The reasons are likely complex, but Poles revisits ideas like incompetence and insight into illness, how these concepts are used to justify overriding autonomy, and how scientific views on responsibility might differ from broader societal ones.
So what's Poles's final message, his concluding thought?
He calls for restoring a balance between the empirical scientific side of psychiatry and its humanistic, person-centered dimensions. He argues we need both. And he suggests the roots of coercion in psychiatry are complicated, not just about psychiatrists wanting power, but tied into deeper societal anxieties and needs for order and safety.
Okay, so wrapping up this deep dive into Pole's analysis of Zaz, wow, we've covered a lot. A really powerful critique of psychiatry's foundations.
And that detailed historical journey, showing how practices and thinking evolved.
Yeah, and this constant grappling with the ethics, especially around coercion and just defining what mental illness is.
It's complex stuff.
For me, some real aha moments were seeing just how drastically things have changed in institutions over the decades,
Yeah.
and understanding the core tension between seeing distress as purely biomedical versus something involving the whole person and their context, that biopsychosocial idea.
And the coercion question just doesn't go away, does it? When, if ever, is it justified?
Exactly. Which leads, I think, to a really big question for you listening to this.
Yeah.
Given everything we've explored, the history, the critiques, the ethical dilemmas, how should we, as a society, try to balance these two crucial things? The need to support people in real mental distress, and the absolute imperative to protect their autonomy, their fundamental rights.
That's the million-dollar question, isn't it?
It really is. It shapes so much of the conversation around mental health care today. So we really encourage you to mull that over. Think about how these perspectives we've discussed might inform our current approaches, maybe even challenge some assumptions.
And as always, we'd love to hear your thoughts, any follow-up questions this sparked for you. This exploration definitely doesn't end here.